Meenakshi R. Ramanathan, the keynote speaker of today's symposium. So, the Meenakshi R. Ramanathan is a graduated from the Pharmacy, University of Texas, Austin, College of Pharmacy, Austin, Texas. And presently, she is working as an Assistant Professor of Pharmacotherapy, University of North Texas System College of Pharmacy. So before that, she was associated with Texas Technical University of Health Science Center, and her clinical practice is an antimicrobial stewardship and infectious diseases. Apart from this, also she is holding several certificates and licenses, including BCIDP, ACLS, BLS, BCPS, and she also received many international honors and awards. She has also quite good publication in the international peer-reviewed journal, that is European Journal of Drug Metabolism and Pharmacokinetics, Journal of Basic Clinical Pharmacy, Texas Journal of Health System Pharmacy, and so on. She was a part of grand rounds and delivered 30 clinical educational presentations. She also published 3 book chapters in Elsewhere books. She is a member of Clinical Practice Site Committee, such as the Infection Control Committee, Antimicrobial Stewardship Committee, PGY Residency Advisory Committee, and others. She is affiliated with many other professional bodies such as AACP, ACCP, IDC, SA. And now the time she is now with us to share her experience on the role of pharmacist in immunization process. So please, Dr. Ramanathan, share your slide and start your talk. Thank you.
Hi, it's morning here, but good afternoon and good evening over there in India and across the globe. Let me go ahead and share my slides. Can you see this okay?
No, it's not visible. Yeah.
You can see it. Okay. So I just wanted to thank Dr. Chitney for inviting me for this talk today. Dr. Suresh Madhavan is our dean at UNT, and he's the one that introduced me to Dr. Chitney. I also wanted to thank Doctors Sahu, Ravi Shankar sir, Srinivasan sir, Dr. Srinivasan and Dr. B. Suresh for the warm welcomes in the beginning. And it's definitely hard to follow Drs. Divan and Siddiqui and Ahuja from this morning, and I'll repeat probably some of the things that they are discussing today, but a lot of the things that I will be talking about is the process that we do in the United States with the role of pharmacists in immunization. I also don't want to forget Mr. Samir Bhargava, because of course he was very, very helpful in terms of the IT technical issues, because we don't use Teams, Microsoft Teams, as much as we probably should over here, but let's go ahead and get started. So some of the session learning objectives that I want to talk today are—
could you please share this slide?
It's not working. Give me 1 second. Let me share it again. Can y'all see that?
Yes.
Okay, so I want to describe the history of immunizations and how pharmacists became involved in the United States. I also want to discuss the role of pharmacists in immunization and also be able to talk about the common screening questions that we can use in terms of trying to see which patients we can vaccinate, and then also talking about education of patients on the benefits of vaccination and addressing any of their myths or concerns about these vaccinations. So I do want to say that I do have some conflicts of interest. I am a small stockholder of Ocugen, who is trying to push for Covaxin in the United States, and then I also hold some stock in Moderna. So the great thing about this year, 2021, is that it marks the 25-year anniversary of the APHA immunization certificate. So this certificate became live in 1996, and during that year, we had about 1,000 pharmacists become immunization certified. And so this is a great milestone in the United States for having pharmacists immunized over here. And if you look at the basis of the APHA program, which I'm going to talk about today, the main 3 roles that they describe in their certification process is that the pharmacist can play a role as an educator, a facilitator, and also an immunizer. So in countries where pharmacists do not have the access to become immunizers, of course, we are the drug experts and we know the most about our medications, and that also includes vaccination. And so we can become educators of our patients and also our other healthcare providers. Pharmacies across the globe can also be sites for facilitation of immunization. So even if we're not able to provide these immunizations, if the pharmacy is large enough, we can try to facilitate other healthcare providers like nurses or physicians come to our practice site and give these immunizations. And lastly, becoming immunizers, whether it's student pharmacists, or even pharmacy technicians. So one graphic that they have in the certification program talks about the US death rate from infectious diseases between 1900 and 1996. Before COVID-19, we have not lived through a pandemic, and unfortunately, we are repeating ourselves with the 1918 Spanish influenza pandemic. But, you know, with the onset of various antibiotics and also our vaccinations, we were able to get the infectious diseases rates down in the United States and worldwide. And so if you look at this, this is very similar, I think, to the graphic that Dr. Devan had in terms of the disease the vaccine preventable diseases that we have. And as you can see here, the very first one being smallpox in 1798, all the way down to 2006, the herpes zoster and the human papillomavirus. So over time, we've released various vaccines to help decrease these vaccine preventable diseases. Based on the data that I have from APHA, there's a lot of benefits to vaccination, especially childhood vaccination. So between 1994 to 2003, we've been able to prevent 322 million cases of disease, and so among children born between 1994 and 2003, 1.4 million hospitalizations, almost 56,000 deaths, $4.2 billion in direct healthcare costs, and $1.5 trillion in terms of societal costs. There's a lot of benefits to pharmacy-based immunization programs. In the United States, pharmacists are actually considered the most trusted healthcare provider and also the most accessible healthcare provider, especially because just like in India, we have pharmacies around every corner. I know Dr. Siddiqui was talking that there is one in walkable distance in the UK for every it takes about 20 minutes to get to the nearest pharmacy. And so pharmacies are open, usually around the clock, longer hours than physicians' offices, the usual 8 to 5, and they are available, in the evenings, on the weekends, during holidays, and so that is one major benefit. Like I had mentioned before, we are the drug experts, so we also know very well about our vaccination programs. Dr. Ahuja had spoken about that we are well experienced in our product storage and handling and safeguarding of the inventory, and our pharmacists are also well trained in medication therapy management, teaching or how to take a medication history from a patient, how to do medication reconciliation. So that can be very helpful from a screening standpoint for vaccinations. They provide a bridge between the patient and the physician. And in the case that the patient is in a more severe disease state or case, we can go ahead and refer them for immediate care to the physician or the emergency department. And pharmacists are also well adept with electronic communication and computerized record keeping. Because of President Obama, a lot of our systems have moved in more of a computerized system, so it's much easier to track, which is a great thing. And then, of course, we do a lot of billing, whether it's Medicare, Medicaid, third-party payers, and so we know how to bill our medications and our vaccinations, as well as administer them. So going more into the history of immunization-based delivery, we were there in the very beginning in terms of supplying the smallpox vaccine and diphtheria antitoxin in the 1800s and 1900s, but truly our place as a facilitator started in the 1980s, where the Colorado Influenza Alert Campaign occurred, and we were having nurses come in to be able to provide the influenza vaccine at a large scale. So we were more of sites for other providers to come in and provide these vaccinations for the population. But around 1993, we started to see pockets of pharmacy associations around the country, especially with the Georgia Pharmacy Association, helping to distribute like the meningococcal vaccine, or even working with other organizations like the Washington State Pharmacists Association and University of Washington to help get pharmacists in the front line of providing these vaccinations. In 1995, the APHA and West Virginia University School of Pharmacy partnered up with the CDC to help with the pharmacy immunization project, which again allowed for facilitation of nurses to immunize children and adults in the community pharmacy. And then in 1996, like I had mentioned before, that was our groundbreaking year where APHA partnered with the Mississippi State Board of Pharmacy and Mississippi Pharmacists and the University of Mississippi to create this model immunization program that they could pilot. And then by the end of 1997, we did have about 1,000 pharmacists trained and 5 million doses of influenza vaccine, which is probably our most common vaccine that we immunize for in these in our pharmacies. In 2001, APHA became a liaison for the CDC's Advisory Committee on Immunization Practices, which is ACIP, and I'll talk more about ACIP a little bit later. So we still have a pharmacy member on that team. Dr. Stephen Foster represents APHA on ACIP and helps in terms of the immunization schedules. In 2002, other organizations from the healthcare perspective, so the American College of Physicians, American Society of Internal Medicine, etc., they backed us up by a position paper saying that, hey, pharmacists can be immunizers too and can free up providers to be able to do this. And especially in the 2009-2010, the H1N1, pandemic, kind of epidemic that we kind of saw there, we had a lot of pharmacists helping with the nationwide rollout of that vaccine. So approximately, we have 300,000 plus pharmacists and student pharmacists trained in the APHA's pharmacy-based immunization delivery program, which is a huge success. I can't say that all of them are actively participating in immunizations, but I remember when I was in school, so I graduated in 2009, and so 2005 to 2009, it wasn't, immunizations were part of the curriculum, but we were not taught to immunize. If we wanted to immunize, we had to go to a day-long program, about an hour-and-a-half drive from the university to be able to become immunization certified. So in all 52 regions, so 50 states plus District of Columbia and also Puerto Rico, we were able to administer vaccinations. Now, depending on the state, it will change who can be vaccinated and which vaccinations are allowed to be given. But across all 52 areas, we can vaccinate in the United States. A term that they've coined from the American Pharmacists Association is called creating an immunization neighborhood. And this is basically a collaboration, coordination, and communication among immunization stakeholders dedicated to meeting the immunization needs of the patient and protecting the community from vaccine preventable diseases. And so that includes, our healthcare providers, so our physicians, nursing practitioners, PAs, physician assistant, and also our pharmacists. So getting everybody involved in terms of this effort, and that also includes our pharmacy technicians, just like Dr. Siddiqui had spoken about earlier. I do want to note a lot of the things that he spoke about in his talk about pharmacist role in the UK is very similar to the United States. So I saw a lot of shifts in the United States in terms of the COVID-19 pandemic from the perspective of pharmacists and also in academia, and I'm sure you guys saw the same things. So we saw an increase in telehealth. And, I think we were really pushing for telehealth, but when the COVID-19 pandemic, we had to do it overnight in order to provide our services, whether it was medication therapy management, medication reconciliation, or even our ambulatory care pharmacists trying to see their patients. So we saw a lot of telehealth. Some providers, physicians would see their patients, the sick patients in person and see other visits via telehealth or vice versa. And so that was one big shift that we saw. And of course, we saw a lot of virtual learning occurring during the pandemic as well. I also saw increases in point of care testing. So I also teach point of care testing at the university. And the biggest point of care testing that we see in our outpatient pharmacies, whether it's Walgreens, Walmart, CVS, it's Brookshire's, etc., is going to be for group A strep, so strep pharyngitis, and also influenza testing. So the patients that require antibiotics actually receive them, or if they need oseltamivir or Tamiflu. And we also saw increases in point of care testing for COVID-19, whether it was the antigen testing, antibody testing, or PCR testing. And so we had a lot of these pharmacies create drive-through sites. So the patient would come through the drive-through, they would do the nasopharyngeal test and go ahead and provide their sample, and it would be processed and run through the insurance, and then they would have their test result. We also saw an increased recognition as immunizers, whether it was pharmacists or pharmacy technicians. And even before the vaccines even got into the storage, these pharmacies were preparing their pharmacists and pharmacy technicians and clerks in terms of how to process everything, how do we store everything, and that type of thing. And I know my students especially have been helping with the point of care testing. They have been helping with immunizations, and then and during the pandemic, another source of income for some of my pharmacy students and even my medical students has been contact tracing, which has been very helpful for the Tarrant County, which is the county that we are in for the university. Pharmacists can help in terms of the provider gap. So I am from the state of Texas, and we don't have enough physicians in our state. So this is 2016 data. We don't have enough physicians, and we need to free up our physicians to be able to do other things. And so in order to free them up, sometimes we need to allow some tasks to be handled by other providers, which in the United States, or actually across the United States, this has been hit or miss in terms of recognizing pharmacists as providers. But every 2 years, our legislature meets in the state of Texas, and we last met in 2019 and now in 2021. And we did have two big wins these past two sessions. So back in July of 2019, we started to become recognized as providers, and we could bill for our services, which is wonderful. But there are some issues in terms of getting that process rolling, and I know a lot of places are still working on getting payment for some of our services. The other really great thing is the Federal PrEP Act. that came out sort of at the beginning of the pandemic. So this is the Public Readiness and Emergency Preparedness Act. And because of this act, we saw a lot of changes in the pharmacies, similar to what I've spoken about already. So pharmacists were authorized to go ahead and order and administer these FDA authorized COVID-19 tests, childhood vaccination. So before COVID-19, we were only allowed to vaccinate within pharmacies from 18 years and older. For childhood vaccinations, these patients had to go to their primary healthcare provider or pediatrician to get their vaccinations. But because a lot of people were hesitant to leave their homes during the pandemic, or even go to the physician's office because you didn't want to get exposed to something, they opened up the pharmacies for childhood vaccinations so that we wouldn't lag behind in the childhood vaccinations, because a lot of these schools were also expecting these students to have these vaccinations prior to enrolling. So definitely the Third Amendment of the Federal PrEP Act helped with childhood vaccinations as low as age 3. And then we had the authorization for pharmacists to order, administer, and even pharmacy interns or student pharmacists to administer COVID-19 vaccines as long as they had their appropriate training. And then pharmacy technicians were also given that authorization, which I'll talk about the history of that a little bit later. And then the last amendment, the 7th Amendment, actually goes over that any pharmacist that had had their license either inactive, expired, or lapsed within the 5 years, that they could still come back and practice, which adds an extra amount of people to go ahead and immunize. Just recently, at the beginning of May 6th, we did have an important bill passed in the Texas legislature, which the PrEP Act allows for pharmacists to be able to temporarily give vaccinations at the ages of 3 to 18, but this bill has allowed us to continue that service even past the pandemic. So that was a big win for us in the state of Texas. In Idaho, so Idaho was the first state in the United States to go ahead and approve extended pharmacy technician role as an immunizer. And then in the APHA House of Delegates in March of 2020, we did have a position statement or a policy statement come out that said pharmacy technicians could also become immunization certified. And so the Pharmacy Technician Certification Board, which is the exam that our pharmacy technicians sit for, now have many advanced certifications, including technician check tech, so technician product verification, medication history, compounded sterile preparation, and now immunization. So now the technicians can also have an advanced certification. So this is the pharmacist patient care process that we use. This is very similar if you're aware of the SOAP note process. And this can also be applied to immunizations from a pharmacist standpoint, in terms of pharmacists being able to collect the appropriate information and assess whether a patient needs an immunization or not, come up with a specific plan for the patient, implement it, and then also doing the follow-up and evaluation and monitoring for the patient. And for those of you that have electronic medical record systems that we can track some of our patients, probably the easiest way to go ahead and kind of screen your patients is, reviewing their medications and attaching them to their disease state conditions. And, based on those, we can kind of figure out, okay, which patients have heart disease, lung disease, diabetes, or kidney disease, and realize that these patients with these comorbidities are going to be at an increased risk for certain diseases, like influenza or pneumonia, and so they need to be vaccinated for these specific disease states. So there are certain questions that you can ask your patients about in terms of screening for all vaccination. So I'm going to talk more about the process and how do you set up an immunization program in the next set of slides, and then I will show you some US data in terms of how the vaccinations have brought us down. So some of the things that the pharmacist or pharmacy technician can ask about is the patient sick today? What are their allergies? So are there any medication allergies, food allergies, latex, vaccine, etc.? Of course, if a patient had an anaphylactic reaction to any vaccine, they probably shouldn't get that vaccine again. What is their past medical history, and do they have any of those comorbidities that might put them at a need for other vaccinations? For live vaccinations, there may be additional questions like with MMR or varicella, etc. So do they have any immune compromising disease states like cancer, leukemia, HIV, AIDS, or any other immune system problem? Are they taking any immunosuppressants, or have they received any chemotherapy or radiation? Have they had any blood transfusions or immune gamma globulin, and received any other vaccinations in the past 4 weeks? Because there are some, spacing issues that we do need to consider with some of these vaccinations. Are they pregnant, or do they plan to become pregnant? And then, also consider if they are, candidates for other vaccinations. So we've talked a lot about vaccine hesitancy today, and I think the biggest ones that I have heard in recent years is especially the flu shot causes the flu, vaccines cause autism, I don't like vaccines because I am needle phobic, and that type of thing. So we do have to be able to sit down our patients and really get to the bottom of why they have these preconceived notions and get to the bottom of it and try to clear some of their fears. And with the flu shot causing the flu, they do have to recognize that it does take about 2 weeks to get full immunity, whether it's the flu shot or the COVID-19 vaccination. And so just recognizing that maybe they got infected prior to getting vaccinated or right after getting vaccinated. And then also, if the patient does have needle phobia, then talk to them about maybe other alternatives. There are some alternatives even for the flu that like intranasal vaccine that can be given to avoid vaccines, the actual needle. So when educating patients of vaccines, these patients have some preconceived notions, and there are about 5 factors that will determine the person's decision to be vaccinated. And I felt that some of this also had to do with their perception of how serious COVID-19 was, because at the beginning of the pandemic, we were hearing, okay, it's only affecting the older population. And so I was seeing an increase in our younger population saying, hey, this doesn't affect me. I'm going to continue to do what I want to do. I'm going to go to the bar. I'm going to go to these parties, and nothing really matters. And so that perceived susceptibility to disease and the perceived seriousness of disease, I think, kind of helped propel the COVID-19 pandemic in the beginning in the United States. And then they started realizing that, hey, this can happen to anybody. And then other things to kind of consider is, what are the vaccine benefits? Will it decrease transmission? Will it reduce you being a carrier? What we've seen with Pfizer, BioNTech, and also Moderna and Johnson & Johnson and the United States is that it helps reduce the hospitalization, severe disease, death. But like Dr. Devon had spoken about earlier, no vaccine is going to be 100% effective in any of these. And so also making sure that the patients understand that. There are vaccine barriers in terms of adverse effects. And Dr. Ahuja spoke about, making sure that you talk to the patients about this. Usually patients are going to see the a higher amount of side effects with the second dose, if there is a second dose, because their immune system has already been revved up by the first dose. And then also talking about access in terms of affordability, etc. Some countries, unfortunately, especially third world countries, haven't even had access to the vaccine, which is very sad, especially with the mortality rate that we are seeing with the disease. And then also social influence. So recommendations from a pharmacist or somebody that they trust, or even social influence from their friends, as Dr. Ahuja had spoken about. So I do want to kind of talk about sort of timeline in the state before I go into some of the maps and how our trends have been in the United States. So we went on lockdown in the United States around March 23rd, 2020. A lot of our schools shifted over to virtual learning the middle of March of 2020, which is spring break. And our governor, Governor Greg Abbott, issued a mask mandate. So before that, it wasn't mandatory, but around July 2nd, they started to put that mask mandate in place. I think the reasoning behind that is we did not have masks in stock or even personal universal precautions in stock, and it needed to be reserved for our hospitals. And so that was a mistake on our part in the United States. And then recently, at the beginning of March this year, they actually removed the mask mandate and they actually opened up 100%. And so this is actually a little scary for me, but I have seen I have seen the disease come down. So there is a lot of hope for India right now. So I want to kind of show you our numbers in the United States. So this is as of the 31st of May, so this past weekend. And if you guys, you may have heard Memorial Day weekend was this past weekend, and that's usually when we honor our veterans in the United States. So Monday was a holiday for us and a 3-day weekend. So I am an infectious diseases pharmacist by training, and I do sit in the COVID-19 ICU, and I can tell you the two biggest times where I was the most overwhelmed in terms of our patient load and running out of beds was probably in July of last year. And then also, so July, it's almost been a year since then. And then also January. January was a very bad month for us and we were running out of beds. I work in a 432 bed hospital, and it's very tough to see us get to possibly a state like Italy. But you know, our highest count was probably January 8th in the United States with 300,000 cases per day. And then in terms of death, February 12th, we had about 5,500 cases of deaths in the United States during that time. And then if you look at us now in the United States, we have about 5,600 cases per day. A 7-day average is about 17,000. And deaths is about 150, and then 7-day average is about 610. In my local state, we have new cases of about 196 with the 7-day average of 1234, and I think the data is still rolling in, but they're only reporting 1 death and 38-day average from May 31st. So it can be done. And then kind of going back, I do want to kind of talk. So Dr. Ahuja had mentioned that the Pfizer BioNTech was released in the United States on, the approval was around the December 14th, and the following week it was Moderna was approved. I received my vaccination around December 23rd, but we didn't see the full effects of the vaccine come down until around January 8th, because I think of the holidays, a lot of people were still meeting up people, whether it was Christmas or New Year's. So we didn't see the full effects of that downslope until a little bit later on. But thankfully, here in July, this came down a little bit because of the mask mandate that the various governors were discussing or had put into place. And it was very sad here in the United States, and I'm sure it was the same across the world, that people were listening more to politicians than their healthcare providers. And so I think that's a place where pharmacists can kind of fill in that gap. Because I know a lot of my friends from pharmacy school were trying to do that via, you know, social media like Twitter and that type of thing. And then in our local county, we actually don't have that many cases as much as we used to. So 7-day average is about 54, 7-day average was about 2. I was in the ICU yesterday, and we didn't have that many COVID-19 patients. So that, I hope it stays that way. But because of the real test of time, I saw this article come out this morning on CNN, and the real test of time is what the effects of this past 3-day weekend is, because the weather is beautiful and a lot of people are trying to get out and go to the beach or have picnics with friends. And so we'll have to see how that is. And of course, we don't have the mask mandate to keep us protected. So in terms of, the statistics, still United States has had the most number of cases, followed by India, Brazil, France, and Turkey. So this was from this graph right here of Texas was from last week on the 26th, May 26th. But our major hubs were Dallas, Fort Worth area, Houston, Austin, and San Antonio. And this is from this morning. And now we kind of see like a chicken pox type of picture. So it's more sporadic than what it was. So there is, again, a lot of hope, I think, worldwide. And then looking at the CDC tracker data that we have, it goes more into a total population in the United States. We have about 40.9% fully vaccinated. So I think it might still be a little too early to have removed the mask mandate, etc., open up everything for the economy, but we'll have to wait and see. And then, of course, in our greater than or equal to 65 population, it's about 75%, which Dr. Anthony Fauci has been saying that we need about 70 to 85% to get to herd immunity, which I'm not sure if we'll ever get to herd immunity because of all of the different variants that are populating. And so I feel like that COVID-19 is going to be more endemic, like influenza, and we might have to get vaccinated. So if you look at the total vaccine doses, I think we can learn from China here, and I'm sure these processes are also already being implemented in India right now. But if you think about the population-wise, China has about 1.444 billion people. India has about 1.392 billion. And then the United States only has 332 million people. China's doing a really good job in terms of their vaccination rates. They're actually doing 4 times more than what the United States is. And I think it has to do, it's due to their marketing strategy. And they are using their celebrities like Yao Ming to help advertise how popular and cool the COVID-19 vaccine is. And then just like sometimes with our voting in India and cash handouts by the politicians, they're doing that, and then also giving away free products like laundry detergent, etc. So that's some processes that we can probably take up also in India. One of the big things that happened recently around May 12th to the 14th was that Pfizer was approved for ages 12 to 15, which before that we had 16 and above could get vaccinated. And I actually got to sit on the ACIP meeting, and it was free, and it was an 8-hour session that day, and I got to sit through it, and it was very exciting to hear all of the deliberations about the vaccine, and then hear some of the testimonials from some of the parents. But because summer just hit and all of our students are out of school, they can now go to summer camps or be able to hang out with friends during the summer a little more safely than before. In terms of addressing adherence, especially in those vaccines that are having a second dose, we do need to have a process in place in terms of talking about the fear, how the vaccine works, the side effects, how to mitigate some of the side effects. Some patients who may have transportation issues to getting to vaccination sites, providing shuttles, etc., reminder cards in terms of immunizations, phone calls, texts, setting up appointments ahead of time for a second dose can definitely help, especially with the COVID-19 pandemic, or whether it's any of the other vaccines that are in a series. So there is a 7-step approach to addressing vaccine hesitancy, and I think that the first thing is to stop thinking that old people are anti-vaxxers or think that vaccines cause autism. Again, you really have to sit down with the patients and see where the issue is. Keep cognitive biases aside, use positive, empathetic language, like Dr. Huja had mentioned, boost their confidence, call out distortions in the science, work with confirmation bias instead of against it, think about telling real patient stories, which I know a lot of people have shared with COVID-19 vaccination, change the default and tailor the message to build the trust. So Dr. Huja kind of mentioned some of these things, but whenever I was talking to people, the one thing about the mRNA vaccination is that it was the first of its kind, and so nobody truly believed in it. But it is a smaller, much easier vaccination to produce. It is considered more active against coronavirus compared to the protein-based viruses. And we've been studying the mRNA-based virus vaccines since the 1990s, so it's nothing new. And in the United States, for the development of these vaccines, yes, it took less than a year, and it may have seemed really small, but the FDA did not skip steps when they developed these vaccinations. They actually, COVID-19 was our main priority, just like in older journals, for pharmaceutical medical journals, the main topic is COVID-19, and those articles were given priority. Same thing with the vaccine or medications. Those were given as top priority. And so it would skip the line. And so if there was a vaccine paperwork on immunization, and after that maybe measles, mumps, rubella, and then some paperwork came back for COVID-19, that was going to be pushed to the beginning. And so that was something that we needed to also consider. So just making sure that patients understand that. Some conversation that can be had in terms of the vaccine hesitancy is what concerns do you have about the vaccine? Or tell me about your understanding of the issue. So you want to have open language when you're talking to these patients. What information, and then also get what their source of information is. Everybody's Dr. Google these days, right? Or Dr. Wikipedia. So see where their source of information is coming from. And then once they've told you their concerns, use language like, I can understand that why you're concerned after reading that. And that type of thing. And then if they've had a bad experience from a previous vaccine, also sound empathetic and tell them, it sounds as though you felt quite miserable the last time you had the flu, maybe the vaccine can help you with that. And then after they've told you all of their concerns, ask them for permission if you can talk to them about how you can relieve some of their concerns. If they say, no, I don't want to talk about it right now, just tell them, as your pharmacist, I am always here for you, and I am here to talk about it when you're ready. So don't push it at that specific time point, talk to them a little bit later. In the state of Texas, in order to upkeep the APHA immunization certification in the state, you do have to have your 3 hours of immunization continuing education every 2 years, 3 years, yeah, every 2 years. And then they have to have the OSHA bloodborne pathogens training, and then also have the cardiopulmonary resuscitation training, CPR training in case something goes south when the vaccinations are in place. And some of my recommendations for incorporating this into practice in India is having the Indian Pharmaceutical Association and state pharmacy associations come up with a guideline and a pharmacist-based training program that can be piloted in one of the states, just like we did here in the United States. Get the backing from the Indian Medical Association and Indian Nurses Association that they're already overwhelmed with the patients in the hospital, and so they're going to need extra help from the pharmacists. And get their backing, and then in the case that we need to train pharmacists and students, have a self-study course online and then have a practical component, or even have a one-day continuing education seminar with a skills assessment. So in terms of the components of these training programs, we need to talk about history of pharmacy-based immunization in India and then worldwide. We need to talk about the connection between vaccination and public health efforts, similar to what Dr. Devon had talked about in immunology and vaccine development information. Discussion of vaccine preventable diseases and the history of these diseases. Talk about the screening assessment for immunization needs, the schedule similar to ACIP and the timing, spacing of vaccine doses. Contraindications and precautions for the various vaccines is very important because there is a liability with these vaccines. So the pharmacist needs to be well trained to be able to identify those contraindications, especially when you're giving the paperwork to the patients. They need to have that information sheet on that vaccine that talks about these are the contraindications, these are the precautions, and they need to sign an informed consent form. Dispelling the myths and misconceptions that they may have and using their appropriate communication skills, using positive language when you're talking to them, being able to be trained in the vaccine administration technique, whether it's a TB skin test or whether it's intramuscular or sub-Q types of stuff. What do we do if we have adverse events occur or emergency response? We need to have epinephrine EpiPens on hand. We need to have diphenhydramine on hand. We need to have the patient seated in an area that is safe in the case that they do have syncope or faint, that they don't hit or have any sort of head injury. We need to monitor these patients and register them for the monitoring. We need to keep track of their immunization records, and then also follow up after the immunizations, especially, and then give them, a future appointment for the immunizations. So steps in operating a pharmacy-based immunization program is going to be, consider your state laws. Which vaccines can we offer? Who can we offer it to? What are the standing order procedures? Do we have to work with a physician or another provider in the area? Decide what's your immunization area. Is your pharmacy large enough to be able to do it in-house? And, have a, semi-private area. And if you have a child that's crying, have a private area where all of your supplies and emergency kits are available. Of course, if you're going to be providing immunizations, you need to have appropriate storage, whether it's refrigerators, cold storage. You need to have running water, a backup generator in case the power goes out. Everybody needs to be trained in the appropriate bloodborne pathogens type of stuff, and employees need to be Hep B vaccinated, etc. So again, vaccine storage and handling, managing of the inventory, especially moving through the earliest expiration dates earlier. How do you deal with vaccine shortages? And then also workflow processes. So in the United States, the way that this has worked is usually we have if we're in an outpatient pharmacy, there's 2 or 3 pharmacists that will rotate shifts, and there might be a little bit of time where there is some overlap in terms of the pharmacists working. So during that overlap time, maybe the other pharmacists can be giving the vaccinations. They can have separate clinics at different times, and then they can also work it in the workflow just like your prescription. So depending on the timing when the prescription came in or the immunization order came in, give the immunization as such. And then you can even get your pharmacy technicians to go ahead and give those vaccines as well. So the role of the support staff, whether it's the pharmacy technician or the clerk, includes marketing, scheduling of these vaccinations, documentation, inventory control, and of course, providing the immunizations. And making sure that you have the appropriate marketing strategies. It would be really nice. I'm sure there are some ads going out there with some of the famous Bollywood actors like Shah Rukh Khan and Amitabh who are, promoting these immunizations. But you need to have signage in your pharmacies saying, hey, the COVID-19 vaccine is here, or the influenza vaccine is here. Ask your pharmacist how you can get it today. And partnering with local groups I know my grandfather is a local Lions Club member, so going to local schools and health fairs and nursing homes to get those people vaccinated, even like large corporate companies and IT like Cognizant, etc. Those might be specific places. Other things to consider is payment for services and billing, which is going to be different from the United States for sure. We also need to consider vaccination for children when we get to that point, and then also we have to be able to cover our pharmacists from a professional liability standpoint, because there is liability associated with vaccinations in case the patient has an untoward reaction. You don't want the pharmacist getting sued because they were doing their due diligence in protecting and helping in terms of the public health issues. So essentially, again, it goes back to the role of the pharmacist, and immunizations boils down to three things. It's going to be education, facilitation if you don't have the access to be an immunizer, and then also immunizing the population. And then, so I guess my final plug-in is that definitely vaccines save lives. As immunizers, pharmacists are uniquely positioned to help against the fight against vaccine preventable diseases and deaths. And you kind of saw that from the data in the United States with COVID-19. And so that kind of ends my talk right there. And if you guys have any questions or wanted to chat with me further, my email address is on the screen.
Yeah, thank you so much, ma'am. It was a wonderful to talk to your lecture, so I noted a lot of points which you mentioned, and you mentioned the recommendations also. So you said the Indian Pharmaceutical Association should come forward and take the support from the Indian Nursing Association and as well as the Indian Medical Association and build a good training program. And once the training program is built, you also mentioned about what the components of the training program should be. And it is very, very important, the components, if they are not being well addressed and the training program is designed without a good component, then it may get failed also. And it's also important to prove ourselves that we are also the part of the team building, and we are there not to capture your job, but we are there to help you out. So to relieve your stress, and that we need to ensure, and as well as inform these Indian Medical Association and as well as the Indian Nursing Association, so that so we can come together. So it's all the patient-centric practice which is very much required. And you also mentioned that the pharmacy technicians and the pharmacists, how they started their journey from the West Virginia University, where our Dr. Suresh Madhavan sir was there earlier. So yeah, this WVU has made a wonderful change in the pharmacy practice, especially I remember the Terry Swingham, so his contribution is enormous. And even the ACP, so we have the ACP accreditation body is also very much focused on to empower the pharmacist with respect to the practicing side. And so thank you so much for all your thoughtful in the insightful talk. And I'm sure so most of the participants will get benefit out of it. And we have noted all your points on the recommendations. So we'll make a note of this on the report, and that report will be forwarding to the Honorable President of Pharmacy Council of India. As he was there in the morning, so he's looking for the report. So we'll comprehend all the experience which you shared, and as well as shared by Dr. Atif and Dr. Alka. So we'll comprehend all the information and we'll make a report and send it to the Pharmacy Council of India President as well as the Secretary to the PCI. And the same copy will also be submitted to the IPA president. As you mentioned, it is also important for the IPA president to know that these are the things which are being recommended by the panelists or the experts from the across the globe. And we'll also submit a copy to the government of Uttarakhand, the state government, and this is the government of India also for their information. And thank you so much for being with us in the early morning at 3:30. So you skipped, I think so. Are you okay now?
Oh yes, I'm fine. I had 2 cups of coffee. I'm good.
Okay, thank you so much. So there are some questions. I think these questions were repeating, and these questions are already being answered by Dr. Alka and previous speakers also, Dr. Prakash Diwan, and again it was answered by Dr. Atif. So thank you so much.